Dear Pure Urology viewers, good evening, one and all. Today, one more interesting topic from Chinese surgeon, Professor Yongda Liu. You know, the complex renal stone management is always complex. The complex renal stones are not only staghorn. Sometimes staghorn large stone is easy to do, but if you have multiple stones in different narrow infundibulae, it is difficult because from one calyx to other calyx, you may not be able to travel. Pelvic stone removal is easy, but peripheral stones which are present in the calyces, you have to do separate puncture, dilatation. All the principles of dilatation must be followed carefully. Supracostal puncture, bleeding, all these problems will be there. Today, can I share the screen? Today, our speaker is Professor Yongda Liu. I introduce the professor, and there is an interesting case posted by a student, and I requested many people were not arguing that this is not necessary. You can do less number of tracts, or you can do RIRS, you can do ECIRS. But let us listen from professor how he has done this case. What is the post-operative follow-up? If you see the CV, he is a secretary of Han Patty Branch, Director of Department of Urology, First Hospital of Gwangju Medical University, MD, Doctoral Supervisor, Postdoctoral Collaborator. Member of the Urological Engineering Group of the Urology Branch of the Chinese Medical Association. Vice Chairman of Laser Collaborative Group of the Urology Branch of the Chinese Physician Medical Association. Deputy Director of the Urology Branch of the Guangdong Medical Association. Standing Member of the Urology Branch of the Guangdong Medical Association. Director of the Urolithiasis Branch of Guangdong Genitourinary Association. Deputy Director of Genitourinary Oncology Committee of the Guangdong Anti-Cancer Association. Member of International Alliance of Urolithiasis. Executive Director of Guangzhou Medical Association. Editor-in-Chief of Urolithiasis Knowledge, Question and Answers, Associate Editor of Ureteroscopy. Fantastic curriculum vitae. With this introduction, I thank Professor Yongda Liu for accepting to present this controversial case, which is difficult to manage, ultimately in the interest of the patient. Ultimately, in the interest of the patient to give stone-free rate without harming the kidney. Thank you, Professor. Please.
Okay. Thank you for your introduction.
Okay.
Now I will share my PPT. Okay?
Yes.
Can you see and hear me?
Yes, yes.
Okay. Good night, everybody. Today, I will share my topics: how to manage compressed renal stones. So, this is the natural history of the residual stones after PCNL. You can see 658 cases of PCNL. After the procedure, 45% cases had the residual stones. In average, 1 year follow-up, if the fragment, the residual fragment, larger than 4 millimeter, 28% cases will require another operation. If the fragment less than 4 millimeter, 16% cases will require another operation. So we should remove all the stone as possible as we can. This is the stone-free rate of single tract PCNL for compressed renal stone. The stone-free rate is only 44%. This is the treatment options for the compressed renal stone. We can center on PCNL or center on RIRS. For the EAU guideline, many cases will be centered on PCNL. So for compressed renal stone, if one TRACT PCNL cannot remove the stone, we will combine ESWL, retrograde RIRS, antegrade RIRS, or perform multi-TRACT PCNL. So if you combine ESWL, it is only suitable to treat residue stones less than 2 centimeters, and the results influenced by the size and the hardness of the residue stone and the weight of the patients and the condition of the calyces, such as the infundibular width and the IP angle. In the AUA guideline, you can see the stone-free lay of combined PCNL combined ESWL is only 66 to 81%. You can combine antegrade laparoscope, flexible laparoscope. If you perform standard PCNL, you can use 18 French flexible laparoscope. If you perform BD PCNL, you can use flexible ureteroscope. You can write the figure. The above figure, you can see the flexible laparoscope cannot reach the parallel calyx. And the below figure, you can see the flexible laparoscope can reach the parallel calyx stone. So you can see the combination of the flexible laparoscope, the effects of was affected by the infundibular length, infundibular width, and the residue stone burden. We should combine retrograde RIRS. We call incurse. We can use GMSV position or prone position. The stone clearance is only 78% in prone position and 82% in GMSV position. So you can see this video. When we use retrograde RIRS, we can see the stone, but we cannot fragment the stone because the IP angle is too short, too sharp. Now,
Yes.
there are some new developments in RIRS, such as urethral acid shift with suction. It can improve the instant stone-free rate of flexible ureteroscope. So, with the new RIRS, the indication of the RIRS were enlarged. You can use RIRS to deal with kidney stone larger than 2 centimeters. But with the new RIRS, it cannot remove the blind spots of the flexible ureteroscope. The main blind spots of the flexible ureteroscope are such as IP angle less than 30 degrees, or the infundibular width less than 5 millimeter, or the infundibulum, the length of infundibulum larger than 3 centimeter. So we use retrograde flexible ureteroscope. Sometimes we cannot reach the caries to deal with the stone. We can use multi-tract PCNL. The pros of multiple tract PCNL, it is not affected by the residual stone burden. Also not affected by the width of infundibula and the IP angle. So if you can puncture, you can take every stone without multiple tract PCNL. But the cons of the multiple tract PCNL are the bleeding and the renal function failure. So how to manage compressed renal stone? I suggest 3 combinations. The first combination is combine ultrasound and X-ray guidance. The second is combination larger tract and small tract. And the third is combination multifunctional laparoscope and the multiple lithotripsy instruments. Now,
Yes.
I will introduce the first, how to combine ultrasound and the fluoroscopy guidance. There are many advantages of ultrasound guidance for PCNL. The first, with ultrasound guidance, it is easy to identify the dorsal renal caries. If we place the probe to the back of the patient, the caries towards the probe, it is the dorsal caries. The second, it is easy to identify where is the calyceal folius. And the third, with the ultrasound, we can easily to identify the adjacent organs of the kidney. Of course, there are low radiation with ultrasound guidance. These are the advantage of ultrasound guidance. So for this case, not very complex stone, only use ultrasound guidance. Only use X-ray guidance, not use ultrasound guidance. You can see after the operation, the patient have hemophagus. We should use the fluoroscope to remove the blood. So you can see only X-ray guidance cannot avoid these complications. Now I will introduce the advantages of the X-ray guidance. The first advantage of X-ray guidance is we can use the retrograde unography to see where is the stone and where is the collecting system. For this case, you can see this is the renal pelvis stone. We perform retrograde unography. You can see this is the branched pelvis. So for this case, we cannot use one thread to remove all the stone. because it is the French renal pelvis. For this case, we must establish 2 TRACT to remove all the stone, so retrograde urinography can provide additional information. If low X-ray guidance, we cannot see these cases with branched pelvic renal pelvis. For this case, ultrasound, we can see the 3 figure. From the left to the right side, the stone is simple and compressed. But the 3 figure, also we can see the hyperacuate area and the posterior shadow. This is, we can say, it is the positive stone under the ultrasound guidance. As we know, the stone in the KUB also have positive and the negative. And under the ultrasound guidance, they are also positive, also have positive and the negative stone. For this case, we only can see the shadow, but we cannot see the hyperacuate area. So we will call this is negative stone under the ultrasound guidance. For this case, we cannot puncture successful under the ultrasound guidance. But this stone in the X-ray guidance, it is positive stone. So for this case, if we puncture failure under the ultrasound guidance, we can use the X-ray guidance. The further advantage of X-ray guidance is it can identify where is the guide. You can see the left figure. The guide is in the creatinine system, and in the right figure, you can see the guide is come out of the creatinine system. It is difficult to use ultrasound guidance to track where is the guide. So when we want to know where is the guide is in the creatinine system or out of the creatinine system, we should use X-ray guidance. Ultrasound guidance cannot tell me the guide is in the creatinine system a lot. The fourth advantage of X-ray guidance, we can use the X-ray guidance to monitor the pathway and the depth of the dilator. Now, these 2 figures to tell us where is the dilator. Is it deep or not deep? For this case, because only use pure ultrasound guidance, you can see the nephron tube enter into the renal vein. You can see renal vein. So X-ray guidance is very important. For this case, 3 TRACT PCNL, you can see the first TRACT and the second TRACT is no problem, but you can see the further TRACT. When we puncture under the ultrasound guidance, we inject the contrast under the X-ray guidance. You can see this figure, the renal vein were indicated renal way. But when we adjust the needle, the origin of the needle, we can avoid venous injury. So during the PCNL procedure, when we inject some contrast under the X-ray guidance, we can avoid venous injury. For this case, also the further threat, when we puncture under the ultrasound guidance, we can see the column was found. So when we inject some contrast, we can avoid column injury. So the X-ray guidance is very important. When we perform the PCNL, we use the ultrasound to check whether there is residue stone or not. You can see it is difficult to see because some block, some water will influence. If you use X-ray, you can see only one residue stone. So use the X-ray guidance, we can easily to check the positive residue stones. For this case, with upper ureter stone, under the ultrasound guidance, it is easy to take out the upper ureter calculi. But in the kidney, you can see a very small stone in this. So with the X-ray guidance, we can puncture to the stone and do not dilate and use the water to replace the stone. And the small stone can remove from the canis to the renal pelvis. So for very small stone, we can use X-ray guidance to take out this small kidney stone. So sometimes, if you use outer guidance to puncture failure, we can return to X-ray guidance. Sometimes we use X-ray guidance failure, we can return to use ultrasound guidance. For the multiple tract PCNL, it is very important to use X-ray guidance. So in our center, we will use ultrasound and the X-ray together. But the ultrasound is first. But for Professor Lemmy, he also used ultrasound in X-ray, but he used X-ray first. This is different. So, which is better guidance? Ultrasound, X-ray in combination. We perform a prospective and randomized trial to find which is the best guidance. The result indicates for the simple stone, such as stone called 5 to 6, the free guidance method, the efficacy and the safety of the free method are comparable. But for the compressed stone, such as stone score is larger than 7, the use of X-ray is very important. It can elevate the stone-free rate. So for these typical cases, very complex stone, we use the ultrasound guidance to remove the majority of the kidney stone. There are 3 residue stone. We continue to use ultrasound guidance to puncture. But after I puncture, I use the X-ray to check the needle is not in the residual stone. So we must change the X-ray guidance.
Okay.
You can disfigure. For the last residual stone, we use the ultrasound guidance to puncture. And then we use the X-ray to check where is the guide. You can see this figure. The guide is come out the collecting system. So for this complex case, you can see ultrasound is very useful, and the X-ray guidance also is useful. So for these complex cases, we should use the ultrasound and the X-ray guidance together. Together is better. The second, I will introduce why I will use the larger and the small TRACT together to manage the compressed renal stones. Nowadays, we can use standard PCNL, mini PCNL, super mini PCNL, and the micro PCNL. This is the standard PCNL, and the mini PCNL, and the super mini PCNL. Different size can cause different result. If we use the larger TRACT, the stone-free rate is higher, and the renal pelvic pressure is lower. But the larger TRACT, the more bleeding and the more severe renal damage. This is the TRACT number. If we perform standard PCNL, the TRACT is small. The renal function were affected. So for this case, we cannot use more multiple TRACT. The number is larger, the renal function is more decreased. But for mini PCNL, it is different from the standard PCNL. This paper is reported in our center. You can see after the operation, for the multiple PCNL, the patient's GFR increased about 9.78%. So after the multiple PCNL, the renal function is recovered, not decreased. So we can combine the large TRACT and the small TRACT to deal with the compressed renal stone. If the stone burden is very large, we can use standard PCNL as the main TRACT. If the stone burden is moderate, we can use mini PCNL as the main tract. If the stone burden is not large, we also use super mini or needle pearl as the main tract. So we use the main tract to remove the majority of the kidney stone, and it can keep the low intrarenal pressure. And so for me, how to choose the main tract? If the size is larger than 4 centimeters and the width of the infundibula is wide, and the stone is very suitable for ultrasonic lithotripsy, I will select standard PCNL. If one condition is not suitable, I will select the mini PCNL. If the stone burden is less than 2.5 centimeters, I will select the super mini PCNL and the needle pearl to deal with the small stone. For the auxiliary tract, we can select needle pearl. For needle pearl, there are low dilation. So it can indicate low dilation, low bleeding, low renal function damage. But we use the needle pearl, we cannot remove the stone. We only use the needle pearl to fragment the stone and push the stone into the renal pelvis and take out by the main tract.
Yes.
If the stone burden is large, or the candice net is narrow, we cannot use the needle pearl. So if the stone burden is large and the leg of the candice is narrow, we must select the super mini and mini PCNL to take out the residue stone. So sometimes we can select the needle pearl, sometimes we will select the mini PCNL and or the SMP. The further combination is I can combine multifunctional laparoscope and the multiple lithotripsy instruments. When we use larger tract and the small tract, we must change the laparoscope from the standard to the mini and to the super mini or the needle. So it's very troublesome because when we change the renal scope, we must change the camera, change the light. So this will have pollution. So when we perform multiple tract, we do not like to change the laparoscope. So for this reason, I invented one multifunctional laparoscope. There are one code of the laparoscope. It can connect the camera and the light crop. When we attach the larger shift, this is the standard laparoscope. The standard laparoscope, the outer diameter is 19 French, and the working channel is 3.8 millimeter. So it can match 20 to 22 as a sheath. When we change to moderate size sheath, such as 13 French, this is the mini nephroscope. When we change the smallest sheath, 8 French, it is the super mini nephroscope. So when I buy this multifunctional nephroscope, we can perform standard PCNL, we can perform mini PCNL, and we can perform super mini PCNL. One scope. You can perform standard, mini, and the super mini PCNL. So you can remove the troublesome and the pollution. And for this case, the standard nephroscope in the multifunctional nephroscope system, the outer diameter is 70 French. But for Wolf standard PCNL, the outer diameter is 19 French. So if you use the multifunctional nephroscope, we can only use 20 to 22 French as a sheath. But if you use the traditional Wolf nephroscope, you must use the 22 and the 24 as a sheath. So there are many advantages of the smaller TRACT. For the smaller TRACT, there are less bleeding, mild renal function damage, and the shorter time of nephrostome tube placement. Sometimes, when we perform different size PCNL, when we perform standard PCNL, often we'll use the ultrasonic lithotripsy. When we perform super mini PCNL, sometimes we will synapse holmium laser lithotripsy. So we should synapse different lithotripsy according to the stone burden and the hardness. So if for the infectious stone, I will synapse ultrasound lithotripsy. When we deal with the very hard stone, I will synapse holmium laser. So sometimes we'll use the needle class. Sometimes I will use the ultrasound. Sometimes I will use the laser. So different stone burden, different hardness, and different lithotripsy tool. So I'll show you some cases. For this case, the stone is larger than 4 centimeters, but the stone is not very hard. The CT value is only 650 HU. So for this case, I use standard PCNL, only use 20 French TRACT. One TRACT, I only use 45 minutes to remove all the stone because this stone is larger 4 centimeters, but the stone is not hard. So I will synapse standard PCNL, 20 French. And the second case, also the stone size is 4 centimeters, but this stone is very hard. The stone value is 1050 HU. So for this case, I will not synapse standard PCNL because I will use the laser, holmium laser, to fragment this hard stone. So I will use the mini PCNL, 1 18 French, 1 14 French together. I only use 55 minutes to eliminate all the stone. So different hard rates, different lithotripsy tool. This case, when compressed renal stone, I will use 1 20 French, 1 18 French, 1 16 French, and 1 14 French, 4 TRACT to eliminate all the stone. This is the infest renal stone, very compressed. For traditional method, we will use 424 French TRACT. If you use this multifunctional TRACT, you only use 420 French. 420 French is better than 424 French. It will less bleeding, less renal function damage. So today, I show you how to compress the
Professor.
out.
Professor,
Okay.
we wanted to see the recent 8 tract PCNL which you have done. We love to see how you have done that.
Okay.
If you have brief
Last
data.
week. Okay. Last week, I performed 14 TRACT PCNL for a very compressed renal stone. I also use ultrasound and the X-ray guidance. I also use the larger TRACT and the small TRACT together. Maybe
Do you have that small clips video?
video. The video is in the YouTube by Mahad. Mahad will show you the video.
Can you show now that video, how complex the stone and what is the reason for so many tracts?
Okay, please wait a moment. I'll prepare the video.
Yeah. For the audience, meanwhile, this presentation is very good, and he not only covered one case. We should never see one case and get feeling of fear or feeling of uneasiness or feeling of unscientificness. This is scientific. He has spoken very well about the ultrasound and the CM tract size, depending on the position of the stone. Majority of the times, it is not the large stone which is very important. It is the arrangement of the small stones in relation with the large stones is important. Infundibulum is important. Ability to move with the nephroscope from one calyx to other calyx is important. Superior calyx to all other calyx is important. Extreme lateral stones with diverticulum type, very important. Long infundibular lateral stones with meaty parenchyma are challenging cases. We have seen through Mahad in Facebook Pure Urology one video yesterday, 8 tracts, and a professor is trying to trace that video. And what is the reason we have to put 8 tracts? Is it justified? A lot of people say that I might have done ECIRS, I might have done the flexible nephroscopy, but the professor has already covered all those aspects. Their experience doesn't mean that just you wanted to put whatever number of tracts. It decreases the GFR, it decreases the function, it increases the bleeding. Still, if you have knowledge, sometimes it is possible to clear all these stones. Is it ready, Professor?
退出，你再进去。
Wait, sir.
Wait a moment. Yeah, 盘呢？先把这个退出。哎，有了。这，啊 ，this way。哦，放我电脑。
You can close sharing and then start.
OK OK。
If you close sharing and then start, it will play.
就没出来吗？哦，还没考过去。Share。Stop 共享。
Yeah. Now you can share, go to the video and play it. Very nice talk. Scientific talk.
就直接访问不行。打不开。我可能没有 MP4，不可能 MP4 谁
It's
都能。
getting downloaded. Wait for.
哦呦，不是这样。嗯？为什么我的拷贝不是？
先把共享关上，先把共享关上，共享关上，共享关上，视频打开，再开共享。
哦，共享已经共享关了。
啊，然后再开去把你的视频打开，再共享。打开不要全打，是打那个小屏幕，然后再播放，不要放在播放那个地方。啊，不兼容吗？
对。
OK。
然后我 zoom 进去，zoom，然后share。
诶，
不是，别下。
哎，这个 zoom 哦，这在共享。
视频打开了，在
就共享啊。哎，这个，这个 ，OK。Can you see the video?
No, screen is sharing. It is taking time.
No， 没有视频。
哦，
没有画面。
共享屏幕可以啊。OK。
Yeah. Fantastic.
That this
See
is
the video
well,
everybody wants to see.
that this is a very compressed stone. Now we'll use the ultrasound. You can see the ultrasound.
Yes.
First, I've used ultrasound to puncture.
Yes.
This is the first thread.
Okay.
And then I have the X-ray to check where is the needle.
Yeah.
So we inject the saline from the ureter catheter.
Okay. Did you inject contrast?
Yeah, inject some contrast. You can see this the
Yes,
contrast
yes.
to check where is the needle, the needle. The
Yes,
needle is whether in the carotid system or not. And then I place the guide wire through the needle.
Yeah.
Yeah, I'll measure the depth of the needle. How depth? Now I make a small incision and take out the needle. Now I use the facial dilator.
Okay. Mahad, as time is short, he can do a little fast forward.
Oh, okay. Like it's step the first thread.
Okay.
This is the 20 French.
Yeah.
20 French. And use the multifunctional laparoscope. So we can use the ultrasound infiltrator only through the 20 French thread.
Yeah.
Now you can see the stone.
Yes.
This stone is infectious stone. So it is very suitable for ultrasound infiltration.
Yes.
Now you can see.
Yeah.
Use the ultrasound infiltration is the very efficiency.
Yeah. Next.
Yes. So this category is very suitable for ultrasound infiltration. Okay.
Yeah.
For the first thread, this the residue stone. So
okay.
I will establish the second thread this way. The second thread.
Yes.
Also 20 French for the second thread. Also use the ultrasound infiltration.
Yes.
So this is the further thread. Also first use ultrasound guidance and the X-ray guidance together. This is very small stone. So I only use the 16 French thread. I do not use the 20 French because this stone is not large.
Yeah.
So I will change the mini laparoscope. Change. So I will establish the fourth thread. You can see the ultrasound is very clear. So for this case, for this puncture, we place the needle in the cipher of the probe, not transverse approach.
Yeah.
So if the needle and the probe is in the same place, the needle will be seen clearly.
Yeah.
So you can see the needle can touch the stone.
Yes, yes. Very well. Fantastic.
Now I will check the X-ray guidance. So for every check, we all use ultrasound and X-ray together. This is the X-ray to check the side of the needle
Okay.
and check them where is the guide wire. Okay, this is after 4-thread PCNL. There are many residue stones. So for the 4th thread, we also can use the ultrasound guidance. But after you perform 4th thread, it is difficult to use the ultrasound. So after 4th thread, I only use X-ray guidance because we cannot use the ultrasound to check where is the renal calculi. So for the 5th thread, I only use X-ray guidance.
Yeah. Hello.
Okay,
Yes.
move faster. Yeah. Oh,
Yeah.
the
Yeah.
5th thread.
Very complex case.
Yeah.
Patient is all right.
Oh, this patient, for this patient, after post-operative day 2, I remove all the laparostomy tube, and the post-operative day 4, the patient discharge.
What is the hemoglobin?
Hospital.
What is the hemoglobin at the time of discharge?
The hemoglobin, the post-operative day 1, the preoperative hemoglobin is 127, and the post-operative day 1, it is 96, and the day 2 is 86.
Okay.
Yeah. Now this is the 7th thread. The 7th thread. Because the 7th thread, for the 7th thread, the stone is larger. So I also use 20 French, use the ultrasound lithotripsy. So different size, use different thread, use different lithotripsy tool. Okay. Oh.
Yes.
1, 2, 3, 4. I don't remember the number of the thread. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6, 9, 10. This is 10.
Oh my God. Are they
Also,
connected? Are
only
they
use
connected?
X-ray guidance.
Are they connected to pelvis?
Yeah, this is the upper pole canis. Maybe 11 tract. Twelve. 13 tract. This is the large, the 15 tract. Okay. Okay, I show you the result. Show you the result. 我有一个这样的东西啊。Wait for a moment 啊 ，wait for a moment.
Yeah. Excellently done. And did you transfuse the blood?
Low
transfusion. No blood transfusion.
low blood infusion.
Not given any blood.
Okay, I show you the okay. This way. Wait a moment, I'll show you the result of the patient. Okay, can you see this
Yes.
PPT presentation?
Yes.
This PPT, you can see
Yes.
2 years ago, I performed the 13 French for this compressed stone.
Yeah.
2 years ago. 30 mini PCNL or 18 and 16 French.
Okay.
So for this case, the operating time is 2 hours and 45 minutes. The hemoglobin of pre-operatively is 13 gram per liter, and the the hemoglobin of post-operative is 17.5.
What is
Okay.
creatinine?
117 points.
What is creatinine level?
体感怎么样？体感。
诶，怎么删掉这个 ？So， 哎呀，
我看到。
What is the creatinine level for this?
Wait a moment. This case, 13 French. You can see, this is the pre-operative, the right side. You can see this is the KUB pre-operative. This is the CT scan pre-operatively, and this is the 2 month post-operatively KUB. This is the CT scan, post-operative 2 months. You can see low residue stone for CT scan. This is the 2 years ago cases for 13 TRACT PCNL. You can see the GFR, the renal function, preoperative GFR of the affected site is 25 millimeter per minute. And this is the post-operative GFR, 2 months is 28 milliliter per minute. So that after 2 months, the renal function is recovered from 25 to the 28. So no severe damage the renal function. This is the two years ago cases.
Fantastic.
So
Thank you.
this is the 15 TRACT. So 15 TRACT, and the operating time is 2 hours and 25 minutes. This is the CT scan after the operation.
Yes.
Low residue. Maybe one small residue stone. Maybe I show you. Very small. This way. Very small residue stone for the CT scan. So for this case, we can see 15 TRACT. We only place 2 laparostomy stone, laparostomy tube, only 2. Not for every TRACT. If we perform 15 TRACT, we place 15 laparostomy tube. It's very painful. So I suggest we should place a little number of tube. Do not place laparostomy tube for every TRACT. And I will place small core. Do not place the larger core, because the size is larger, the patient will feel more pain.
Thank you. Yes.
Okay, thank you very much.
Thank you. We will, it's a great session, great surgery, absolutely scientific. Can we close the screen? Screen close.
Okay.
Thank you very much, Mahad. You have really done a great job. So fast time, you have taken pain. Entire India will watch tomorrow, day after tomorrow, same link forever. Extraordinary talk. One of the best talks I have listened. Very good. Thank you very much.
Sir.
Thank you very much, Mahad.
Thank you very much.
You can ask the professor about the case and follow up and these things and the multiple TRACT. He will answer you, sir.
Yeah. That's what I'm telling. His hemoglobin is 15 and it has come to 10, and post-op day 4 discharged. What is the creatinine in the immediate post-operative period?
体感那个患者的体感多少？术后的那个体感 creatinine
说什么？
体感
什么叫基点？
体感 creatinine
Kidney function test, renal function test.
Creatinine.
Yeah.
体感
Because the affected side is not the main kidney.
Okay.
The left side is the main kidney. So the post-operative creatinine is normal.
Yeah.
But
do you use ultrasound? Do you use ultrasound trajectory for the ultrasound guided puncture? Trajectory, ultrasound.
定位招生的定位，你用那个放那个里面还是没有说 hand free。
Oh, I use the ultrasound guidance as freehand ultrasound guidance.
Oh, difficult. It's really difficult.
Yeah, because for the expert surgeon, freehand is better because the fray after you use many cases, the fray will deshape.
Yeah.
Deshape.
Yeah. Yes.
So that if you use the fray, it is not very
Clear.
clear.
Yeah.
So I think for familiar ultrasound urologist, you can use the freehand guide ultrasound guidance. It is better. And I use the through the side. The needle is nearby the pro, not transverse.
I got the point. By the side.
Yeah. Side approach,
Side-
not transverse approach.
I got the point. Yesterday, Jung shared the same thing. Fantastic presentation. Thank you very much once again. Thank you, Mahad.
Okay.
Thank you, Professor. Thank you.